Rosenthal about single port is not beneficial?
I didn't prepare that, but there's nothing you can say, Julio. That's all you can say about single port incision. Yeah. I was going to have a cognac before I started this talk. How does it go forward? I have to click. Good. My job is to kind of question if single port is beneficial in bariatric surgery. How do we advance these slides? Clicking. That's the Mac. This is not Mac. Let me see. Here we go. Good. Not here. Okay. Good. So the rationale for single port laparoscopic surgery. Those who claim that this has a benefit, and Dr. Teixeira, I'm sure, is going to talk about that, claim that there's going to be better cosmesis. And my question is, in a patient with a BMI of 50, are we talking about cosmesis? Less pain? Where's the data? It's so difficult to document pain in the post-operative period. We well know that pain is a cultural issue, that there are some patients that you can cut a life and they will smile at you, and some others that you touch and they're going to be screaming. So difficult to put that in numbers. Patients' preference, they say, oh, patients are going to be asking you for this procedure. I never heard about one, at least at the Cleveland Clinic in Florida, and I've been there for over 10 years, that came to the emergency room asking me for sales or SPB, or you want to name it. There are so many names now. In fact, when I tell them we're going to do it with little cuts, I say, oh, you're not going to cut me open? So they're still thinking that we can do this operation without laparoscopy even. And they're calling it scarless surgery, and I would call it rather scary surgery. Define the benefits for surgeons and the industry. Obviously, the more new things you can talk about, the more publications and presentations you're going to have, and the more tools you're going to sell, the more profit the industry is going to make. So this, in my opinion, is driven by a group of surgeons with the backup of some companies that are developing new tools. Regarding the data, where are the publications? These are all case reports about transumbilical single incision sleeve gastrectomy, a procedure that has been now kind of endorsed by our society, that we still don't have the long-term results, that we're still evaluating. We are now changing the approach and changing the procedure. The long-term results of most likely single incision sleeve gastrectomy are going to be, in my opinion, a catastrophe when it comes to weight loss. Obviously not when it comes to cosmesis. So when we talked about cosmesis and we look at this patient and you look at 5 or 6 trocars and we look at this patient with 1 trocar, it's like when you go to the ophthalmologist and they tell you, can you see here? Can you see here? Can you tell me if there's a difference in cosmesis between this and this? Where is really the cosmetic advantage of having that 1 little cut compared to these 5 little incisions? And I tell you that the first, the second, the third day or third week, you might have a cosmetic advantage. But if you look in this, for instance, patient, at 3 months, at 6 months, there is no advantage at all. When we talk about pain, we talk about the pain that you can decrease when you compare a subcostal incision in a patient that underwent a laparoscopic cholecystectomy. And here you see what happens at 3 months and 6 months. You don't see anything. So it is a temporary cosmetic advantage that you're going to give these patients. It is not real cosmesis. It's only temporary. But patients don't understand, don't know. They believe in what we tell them. The same thing with bariatric. Pain and cosmesis. Hello? Can you tell me what's the cosmetic advantage here of having 1 incision here or 5 scattered around? In fact, you don't see the trocars anymore in this patient that had a gastric bypass done laparoscopically. But the pain compared to somebody that has it done through a midline incision is remarkably lower. So I don't understand when we talk about cosmesis and pain reduction in bariatric surgery by utilizing the single port incision. And more important than that, it is not the number of incisions that are going to result in less pain. It is the size of the incision. Because 5-millimeter trocars, and this is an old dictum in laparoscopy, 5-millimeter trocars do not cause pain or minimal pain, and they don't leave a scar behind. In fact, I teach my fellows all the time, when you're in trouble, put 1, put 2, use 5-millimeter trocars, add a suction, add a retractor. Never stick to the number of trocars. It is the size that really matters when it comes to decreasing pain and general surgery. Safety, safety, safety. If there is something I think we should really emphasize in 2010 in whatever we do is safety. Exposure and dexterity, both of them are severely compromised when you do single incision laparoscopic surgery, and more so in bariatric surgery, unless you know the patients I'm operating in Miami are totally different to the ones they're operating in New York or in China, wherever they're doing it. Oh yes, don't forget that now we have to cross our hands. But the industry has those new instruments, hello, and now the robots are coming into play, because the robots, when you're going to move your left hand, they're going to move the right hand down there. So now we're going to add the robot to make it happen. So this is what we're talking about, dexterity. And they're making science out of this, you know. They're making science out of you having to cross your hands to achieve your task and decrease your dexterity. I think the principle of safe surgery are all left behind when we talk about single incision. Traction and counter-traction, triangulation, and the ability to dissect, to have a critical view, exposure, and control of critical structures. I remember when I practiced in Germany and we had a bleeding during laparoscopic, during open cholecystectomy, the chairman will come in, the first thing he did is he took the knife and he increased the laparotomy, because we used to do it through the mini laparotomy. The first thing you do when you are in trouble, you increase incision, you try to improve exposure, and here what we are trying to do is to compromise our view. Exposure, critical view, the ability to see from above, from the right, from the side, but not always from below looking upwards. The ability to have not only one port, not only one point of triangulation and visibility, but multiple ones, so you can move your camera to better see, to get closer to the structure. So I think that when you perform single-port bariatric surgery, all basic principles of safe surgery are lost. You're compromising the outcome of patient safety in order to achieve a short-term cosmetic advantage. And how about prolonged OR time? I mean, it is well known in the literature. It is well known in the literature, specifically in the bariatric literature, about longer time in the operating room, rhabdomyolysis, atelectasis, pneumonia, and so forth, when you take longer time in achieving your task. But it seems like time doesn't matter anymore. How about cost? Well, longer OR time, new equipment. You know, I can tell you all these new little toys that are coming to us. And you know, the comments say, well, you know what happens? The good thing of this is it's going to develop new instruments. Hello, I don't want you to be developing new instruments with my daughter on the table when you're doing a single port appendectomy or cholecystectomy. 10 reasons why single port bariatric surgery will not prevail. It has a short-term cosmetic advantage. It prolongs the OR time that will result in more anesthesia-related adverse events. Poor exposure, loss of critical view, and most likely that will result in more intraoperative complications. The lack of triangulation and less dexterity, the inability to have traction and counter-traction, the increase in umbilical hernias where you put the port and 2 or 3 trocars in addition to that might result, when it comes to bariatric surgery, in serious post-operative complications. Requires retraining of master surgeons that will result in lack of surgeons' acceptance. I've been talking to a lot of those that started say, well, I'm not doing it anymore, really, it makes no sense. No insurance coverage. There is no insurance going to cover you for those costs. Lack of data and 10-year follow-up. Less pain? Show me the data. Show me really a good prospective randomized trial showing me that single incision has less pain than when you do it with 5 incisions. More direct and indirect costs. And the questions that need to be addressed, and those are, is really single port in surgery, laparoscopic surgery. And I think we really don't get it, because when we do a procedure, the American Medical Association has a vignette. And in that vignette, if you read it, they're going to say a laparoscopic cholecystectomy, you put several chokers in. They don't tell you where, but they say several. And it's very clear about that. And the same thing, we had it when we started doing gastric bypass. We said, well, laparoscopy is the same that open. If you open the books at the AMA, you're going to say the abdominal cavity is accessed through a midline incision. I don't believe that single port bariatric surgery is equivalent to the standard laparoscopic bariatric surgery we are doing nowadays. And this may have legal implications. We should do this with an IRB protocol. This should be done with IRB protocols. But my question is, what's going to be the hypothesis? What are you going to come to your IRB and tell them, we're going to do all this, it's going to take us longer, we're going to spend more money, and for what? You know, you have to be very careful whom you're following here. And this little dog here who is supposed to take the soldiers in the battlefield is saying, can't smell a thing. And I think this is really what's happening. We are following people that they really don't know where they're going. They really don't know where they're going. They're pushed by the industry, and they're pushed sometimes by themselves in trying to get the cutting edge, and they don't know where they're going. And while one could argue that progress depends on the unreasonable man, and if we won't be trying to do all this, we probably will not be nowadays talking about doing laparoscopic surgery. Some others might argue that man has such a predilection for systems and abstract deductions that he's ready to distort the truth intentionally, he's ready to deny the evidence of his senses only to justify his logic. You know, some people say, well, remember lap chole? When we did lap chole, it was the same. It took me 4 hours. But there was a price to pay, as I show you with the incision: decreased pain, decreased wound infection, early recovery. There is no price we are paying here for, because we really don't know why we are doing it. So is there a future? I think Dr. Teixeira is going to tell us if there is a future. I personally think that if we're going to look into a future in doing these kind of procedures, we need to do them on an IRB protocol with informed consents that are properly done, and we're going to need prospective randomized studies. Thank you very much.